sinuses, even the brain, and so forth. So when you see it, it's a very bad-looking tumor. It is cytokeratin positive, but it doesn't have much else that will be positive. Variably for NSE and very little else. So it's negative for neuroendocrine markers, it's negative for squamous markers, and so forth. Here's a radiograph showing how these tend to be very bulky, destructive lesions. Here you see it occupying and displacing the septum, extending into the sinus, up into the frontal sinuses, and maybe even a little bit of destruction of the cerebral olfactory plate there. Here's the representative microscopic picture. Lots of small cells, very undifferentiated appearance, and notice that we have intact surface. Necrosis is a very common feature with this tumor, and so it will look very high-grade, epithelial appearing, necrotic vascular structures. Here's some vascular invasion there. Here's another image. It can invade through bone. Here, it's coursing through the bone. And here, this may be vascular invasion. Central comedo-type necrosis also can be seen. So it can be a very bad-looking tumor. It looks like it ought to be small cell carcinoma because the nuclear characteristics show molding, very fine granular chromatin. Good morning. We're talking about sinonasal tumors. This is small cell or sinonasal undifferentiated carcinoma that we're talking about. Yeah, very high grade, bad-looking tumor. And so this can be mistaken for a neuroendocrine type tumor because of the molding and the very undifferentiated appearance. But it should be negative for neuroendocrine markers. You'll see areas of single cell necrosis, apoptosis, and so forth in this tumor. Looking at this, you might even think lymphoma as a possible consideration because a lot of small blue cells not holding together very well. But if you look around enough, you'll see some areas where they stick together and are more like carcinoma. Here's another example, more images showing these variable amount of cytoplasm, some very little, some a little bit more, occasionally a little bit of trabecular pattern, sometimes a little suggestion of spindle cell appearance. So just different patterns of growth can be seen with this tumor. All of them behave badly. Here's one of the cytokeratins that will be positive, the very low molecular weight, CAM 5.2 or cytokeratin 818 will be positive. And here's a pan-cytokeratin will also highlight these cells. Aside from cytokeratins, there's very little that will stain with them. So in addition to what I mentioned about sinonasal neuroendocrine carcinoma, you might also think about lymphoma, as I mentioned, or lymphoepithelial carcinoma, which can have a lot of small cells. Ewing sarcoma can also rarely occur in this location and would be considered. So a CD99 might help you differentiate that possibility. Melanoma, of course, can look like anything, so you always need to rule out melanoma. And then rhabdomyosarcoma also can be a small blue cell tumor, have necrosis, single cell apoptosis, and so forth. So a myogenin marker would also be indicated. So here's lymphoepithelial carcinoma, small cells, some bigger cells. That usually is not as big a consideration. But these tumors are more common and can be bulky as well, so that the overlap might be present in a biopsy. With lymphoepithelial carcinoma, we'll talk more about this a little bit later, but the Epstein-Barr connection would help to differentiate this. I don't think you have this inside the hybridization. But lymphoepithelial carcinoma is fairly common.
Yeah.
Right? Yeah. So you might want to think about that.
Yeah, I think what happened inside the fourth, sixth.
Oh.
Yeah, the name of the company.
Okay, I'll see if I can find what the name of the probe is for this EBV.
I'm looking for that hole, but it doesn't have.
Okay.
Maybe better.
So Ewing sarcoma also can have a very epithelioid appearance sometimes, as you see here, sort of cords and nests of cells. But these would be CD99 positive, as you see here, whereas sinonasal undifferentiated carcinoma will be CD99 negative. And melanoma, again, here illustrating that for melanoma, we like to use a different non-brown chromogen, here a red chromogen, to help highlight true positivity from the melanin production that might be present in a case. Now, usually if it's making melanin, you're not going to be mistaking it for sinonasal undifferentiated carcinoma, however. Mucosal melanomas can masquerade as many different sorts of things. And here's a nice high-power view. The melanin is present, so it's easy to recognize from that standpoint. But if you take away the melanin and just look at the cells, you get some molding, you get very poorly differentiated cells, and it could be easy to confuse. And then rhabdomyosarcoma, also high-grade, small cells, mitotic figure, apoptosis, easily concerning for sinonasal undifferentiated carcinoma. Myogenin will help you with that. So here they are at high power. You can see where some of the overlap is between these different entities. And so most common of these are all rare. Nasopharyngeal carcinoma is the more common, but all of these are rare. And so distinguishing one rare tumor from another may require that we go back to the books or go back to our references to distinguish them. There's another tumor that also can appear in this differential diagnosis. This is a more recently described tumor, so-called nut midline carcinoma. It occurs in this location as well as several other locations in the thorax, maybe even in the pelvis, more uncommon there. It affects all age groups, and because it occurs in the head and neck as the more common area, I thought we would mention it here today. So this has characteristically an undifferentiated carcinoma appearance, but then there usually are these sharp foci of differentiation, of keratinization, with a very sharp interface. And if we do the cytokeratins, the CK818 will stain the undifferentiated carcinoma, whereas the CK56 will not, but it will stain the well-differentiated areas. It's called a nut midline carcinoma because it has this characteristic translocation from the VRD4 gene to the nut gene, which can be demonstrated with an antibody. We don't use this or see this enough, so this is sent to somebody else and let them test it to confirm it. It may be that this is not critical, if you recognize the morphology, which can be quite characteristic, and you rule out the other possibilities, like rhabdomyosarcoma or other sorts of things. It's a very aggressive tumor, but it does respond to treatment with the chemotherapy agents that we use for Ewing's sarcoma. So here is a nice example of this. And you see this very sharp demarcation between the undifferentiated tumor and the nice keratinizing epithelium. Very low grade appearing sort of stuff, but very high grade over here. So in some ways this is like, say, a mesenchymal chondrosarcoma, where you have very undifferentiated areas and very differentiated areas right next to each other. So let's go on now to another tumor that we need to consider, which is sinonasal neuroendocrine carcinoma. Again, this is an uncommon tumor and is probably related to olfactory nerve and so forth, but it's not olfactory neuroblastoma. So it doesn't have the characteristic of neuroblastoma. It's more of a differentiated neuroendocrine tumor. The treatment is usually combination therapy, surgery, and chemotherapy, and survival can be not unreasonable depending on the grade and the stage of the tumor. So histologically, it looks neuroendocrine with sheets, ribbons of tumor, trabecular patterns can be seen. And the cells tend to be a little larger with a coarse chromatin than in some other neuroendocrine tumors. We should see necrosis and mitosis to classify it as a carcinoma. The staining will be typical for a neuroendocrine tumor with the neuroendocrine markers. So here's a nice example of what this looks like. As you can see, they're a little bit larger cells. Not a lot of cytoplasm, but a little bit. And the chromatin can occasionally have nucleoli, so it's a little coarser than the sinonasal undifferentiated carcinoma. Here again, you see a few nucleoli, a little bit of cytoplasm, lots of mitoses, including atypical mitotic figures here. A high-grade tumor, but with a little neuroendocrine type of feel. Now, if you just have one field to look at or small sample, you'd have to do the full workup to exclude sinonasal undifferentiated carcinoma, maybe lymphoma or melanoma, with a picture that looked like this. But once you had your neuroendocrine markers, this should confirm the diagnosis. So here they are side by side, and you can see, you know, this actually has more molding perhaps than this does, although there's some here. The chromatin is maybe a little bit more coarse than it is here, but very, very similar between these two tumors. So always keep both of these in mind as possibilities. Now there's another difference that we would employ for sinonasal neuroendocrine tumors, and that is that we will use the regular checklist, and this has not been updated to reflect the new mitotic figure grading and so forth. So it acknowledges that we may have lower grade versions of neuroendocrine tumors in the sinonasal tract. What we've been talking about would be the small cell carcinoma or neuroendocrine type tumor that has atypical mitotic figures, necrosis, and invasive characteristic. This large cell variant is more unusual and would be more likely to be confused with, say, a Schneiderian carcinoma or lymphoepithelial carcinoma or something that had a little larger cells. So, any questions about those two more rare tumors, sinonasal undifferentiated or neuroendocrine carcinomas? Okay, we'll go on and talk about sinonasal adenocarcinoma, which is another very interesting topic because of the differing morphologies that we see here. This has been classified into roughly 3 broad groups. There are salivary gland type adenocarcinomas that can occur in the sinonasal tract because of the proximity and because of the morphology. I'm not going to talk a lot about these at this point because we just talked about salivary gland tumors last week. But we will talk about these other 2 types, the intestinal type and the non-intestinal type. And so these have these acronyms: intestinal type adenocarcinoma or non-intestinal type. So first, just in terms of frequency, the salivary types are actually the more common. Mucoepidermoid, adenoid cystic, and so forth, more frequently seen. The intestinal type would be the next more frequent, and then the non-intestinal type would be less likely overall. So talking first about intestinal type, men are more frequently seen than women. It involves the ethmoid sinus most commonly, and so it tends to be a very deep type adenocarcinoma. It's not in the maxilla or the frontal sinuses, it's back up in the ethmoids. They usually will have some symptoms, and there may be some occupational exposure. Notice what's on this list. So be careful when you're being involved in the grossing area. And handling formaldehyde, it does have a small association with this. Now there are a couple of classification systems that are in use. Quite frankly, we tend to use Dr. Barnes' classification, which essentially says architecture, colonic type, solid or mucinous type, and then mixed. So fairly purely morphologic than the ones from the German group, Kleinsasser and Schrader. Aren't those great names? So histologically, this often will resemble the GI counterpart, so it's not hard to recognize as intestinal type. And it also has intestinal type markers, the CDX2, CK20, sometimes CK7 will be positive in most cases. Now, the interesting thing about this is that this type of intestinal type of adenocarcinoma in the sinonasal tract also can occur elsewhere in the respiratory tract. So we occasionally will see colonic type primary lung tumors that are essentially a continuation of this type of tumor as well. And they may have these markers as well. So it can get confusing sometimes. So here's an example, tall columnar cells with stratification and mitotic figures and so forth that we see. Another example here, they'll stain with intestinal type markers. So it is truly an intestinal type of differentiation. CK20 also can be positive. So this, once we say, hey, this looks like colon cancer, and we do the markers, that should confirm the type of tumor we're dealing with. Variation in morphology, strands of cells, small nests and clusters, loosely invasive background, also could be a colonic type, intestinal type sinonasal carcinoma. Another variation on this would be a pure mucinous tumor. And so these types of tumors might be positive with intestinal type mucins. So the MUC2s and so forth that you might see with an intestinal type would be expected in this situation. Notice that there may be an intact surface. So you also have to say, could this be metastatic? what is more common, primary colonic carcinoma or mucinous sinonasal carcinoma? Well, probably colonic carcinoma or mucinous carcinoma of the stomach may be more common. So you have to make sure clinically that they don't have a tumor somewhere else that has metastasized here and presented as a primary tumor. The markers may not help there because this will have intestinal type markers. So you have to go back to your clinical colleagues and say, we sure there's nothing in the stomach, we sure there's nothing elsewhere. And then there are the mixed types that have some mucinous differentiation, some columnar type, and a more trabecular type as well. This is hard to tell that it's mixed from just one high power field, I know. Here's another illustration of this, showing the columnar, typical columnar type that would be sort of moderately differentiated. Here on this one, more poorly differentiated, solid and nested categories, the mucinous type and other types that we've talked about as well. So the non-intestinal type adenocarcinoma, again, is less common, even less common than the intestinal type, and will present with sinonasal symptoms. In contrast to the intestinal type, which was more common here, this type tends to be more frequent in the nasal cavity and may have multiple sites of involvement. So a little different distribution. So if you see something that's a nasal type of tumor, it's more likely to be this than it is to be intestinal type of adenocarcinoma. There's a couple of terminology issues, so we can